Wish you a wonderful day. Today we are going to discuss on the physiology of blood. This is the part 2 lecture. Here are the learning objectives for this particular lecture. We'll be discussing on the functions of leukocytes and platelets. We'll be discussing on the steps involved in hemostasis. We'll be also discussing on the major blood groups and blood typing and ABO system and RH system and its importance in pregnancy and blood transfusion. When we mix the blood with an anticoagulant, the blood doesn't clot. After that, take that test tube, keep it inside the centrifuge machine and centrifuge it for about 3000 rotations per minute for half an hour. Then you will be seeing 3 different layers in the test tube. As you can see in the right hand side of the slide, that these are the 3 layers. The upper layer is the plasma layer, which is consisting only of the liquid portion of the blood. Then you can see a buffy coat or a buffy layer, which is consisting of leukocytes and platelets, and the last layer, which is the erythrocyte layer, which is contributing to 45% of the whole blood. This is also called as packed cell volume hematocrit or PCV. In this picture, you can appreciate the buffy coat, which is containing leukocyte and platelet, this middle layer. Please remember, in those conditions where the leukocyte count increases, for example, if the patient is suffering from leukemia, you can expect the buffy coat, the thickness of the buffy coat might increase because the number of cells is more than the normal range. Again, when you're looking at the color of the first layer, what is the color of the first layer? It is almost a straw yellow colored. So that is the normal color of the plasma layer. If this color becomes deep yellow, such as in cases of jaundice, when there is excess bilirubin in the blood, you can appreciate that the color turns to deep yellow. And also the last layer, which is the packed cell volume or hematocrit, in cases of anemia where there is an absolute decrease in the cell count, you can see that this layer might be lesser than the normal one. So based on these packed cell volumes and the hematocrit appearance, you can also come to some conclusions about what kind of disease they are going through. Now we will see about the different functions of leukocytes. Leukocytes are also called as white blood cells, and they are formed elements which are seen in the blood, same like RBCs and platelets. They account for less than 1% of the total blood volume. And if you look at the average count, here it is mentioned, this is the average count of the leukocytes. They are important for body's defense system against various diseases. WBCs can leave the blood by a process called diapedesis, where they can mount an immune or inflammatory response. Let us now look at the different types of leukocytes, what we can see in the circulation. You can see that the leukocytes can be generally classified under 2 categories: granulocytes and agranulocytes. Granulocytes are those leukocytes which are having granules in their cytoplasm. Look at this. In the cytoplasm, they have these specific granules. So this one is a neutrophil, and here you can see the eosinophil, which is having the granules. Whereas those cells which come under the category of agranulocytes, like monocytes and lymphocytes, those cells we don't see specific granules. Look at this lymphocyte cytoplasm, which is granule free, and in the case of monocytes also you don't see any granules. Monocytes and lymphocytes comes under the category of agranulocytes, whereas basophils, eosinophils and neutrophils that come under the category of granulocytes. So you can classify granulocytes in a simple way. You can remember it as BEN, B-E-N, basophil, eosinophil, and neutrophil. They are granulocytes. And these are the percentages you can see here. 50 to 70% is contributed by neutrophil. Then you can see lymphocyte is contributing 25 to 45%. 2 to 4% is eosinophil. 0.5 to 1% is basophil. 3 to 8% is contributed by monocyte. Among all those WBCs, the largest among all the WBCs, they are the monocytes. Now let us see what are the different types of granulocytes. As I mentioned, the granulocytes can be easily remembered by the keyword BEN, B-E-N, basophil, eosinophil, and neutrophil. Now the granulocytes, they have lobed nuclei and they have membrane-bound cytoplasmic granules. That is what you see. These are the cytoplasmic granules, what you see in the granulocytes. And granulocytes are functionally phagocytes. What do you mean by phagocytes? Phagocytes are the cells that are capable of eating up other cells or any debris. They eat up invaders. So one of the exception here is the basophil. The basophil will not be having the phagocytic functions, whereas neutrophil and eosinophil will have the function of phagocytosis. So in the neutrophil, you can see the fine granules in the nucleus, and they respond to both acidic and basic stains. That is the reason they are called neutrophil. They are neutral to both stains. So they take up acidic and basic stains equally. Eosinophils will be having granules, and the color, you can see that it is almost like a pinkish or a reddish nature. Basophils have large histamine containing granules, and these cells, especially the basophils, which will be involved in the inflammatory reactions, and also it attracts other RBCs to the site of inflammation. We will see the functions of neutrophils. They are phagocytic cells and phagocytic specialists releasing granular protein that bind to kill a bacteria. Neutrophils are considered to be the first line of defense against any bacterial invasion. That means it is among all the type of WBCs, whenever there is an infection, it is the neutrophil which comes into the picture first. They are considered to be the first line of defense. Clinically, an increase in the number of circulating neutrophils is called as neutrophilia, which signifies a bacterial infection. Neutrophils are polymorphonuclear. What do you mean by polymorphonuclear? Poly means many, morpho is the morphological feature, and morphonuclear, that means the nucleus appears in different forms. You can appreciate that from this picture. You can see that different lobes are seen and different shapes are seen. So this is a typical a picture of an atypical nuclear segmentation in an 80-year-old patient with bilateral lobal pneumonia. So just to show that the nucleus of the neutrophil, they are polymorphonuclear. The shape will be different, the number of lobes will be different, and so on. Eosinophils. In conditions like hay fever or asthma, bronchial asthma, these cells will be activated in larger number, and in circulation you'll be seeing that it increases more than the normal range. So in this picture you can see that there are pollen grains. So this is from the flowers, the pollen. Some of the people might be allergic to the pollen grains, and hay fever means it is also called as allergic rhinitis. Sometimes some of the individuals might have, whoever is having this allergic rhinitis, they might experience this kind of situation when they get up early morning. They might be feeling, they will be having running nose, and they might be sneezing for at least for 1 hour duration. So after that it slowly subside. So in those conditions the eosinophil count will be increased in the individuals. It is also seen in hookworm infections, parasitic infections. So you can see in this picture that in the intestinal mucosa, the hookworms. So during hookworm infestations, asthma, allergic reactions, conditions like hay fever, etc., you will see the eosinophil count increases more than the norm. Basophils. These cells play a major role again in the allergic reactions. Again, in conditions like hay fever and asthma, you get to see this kind of condition. It is involved in the inflammatory responses. They contain a natural anticoagulant called heparin. What is an anticoagulant? We saw that in yesterday's lecture. Anticoagulant is a substance that prevents blood clotting or coagulation. So in the body we already have a natural anticoagulant which will prevent blood from clotting. So that anticoagulant is made by the basophil. So it is having a very important role. It is also involved in releasing the vasodilator substance, histamine. Histamine is also acting as neurotransmitters in many parts of the nervous system. This will be promoting vasodilation. That means the blood vessels dilate, the blood flow to that particular surface increases. That is the reason why you are seeing this redness in the patient. Wherever there is allergic responses, you will be seeing redness because there is vasodilation and increase in blood flow to those areas, and that areas will appear red. They are non-phagocytic cells. That means they are not capable of engulfing the substances or bacteria or any foreign substances. They cannot engulf. Now we will be looking at the characteristic features of agranulocytes. Agranulocytes are the cells, WBCs, which doesn't contain granules in it. They do not contain visible cytoplasmic granules. Their nucleus are spherical or kidney shaped. Lymphocytes. In this picture you can see the lymphocyte, how it looks like. They are slightly larger than the red blood cells. They have a large purple nucleus. Usually they reside in lymphatic tissue and play a role in the immune response. Monocytes. Please remember, monocytes is considered to be the largest among all the WBCs. They are very important in fighting chronic infections like tuberculosis. Monocytes. Monocytes are released in an immature form from the bone marrow, and it will be circulating in the blood for about 2 days. After 2 days, these monocytes will get lodged into various tissues, and then it will be transformed into macrophages. So these macrophages are nothing but they are monocytes which has gone into the tissues from the blood, and they will be having that phagocytic functions. They are considered to be the big eaters. They are professional phagocytes. They will be living for months and years ingesting foreign materials. So remember that when it is released from the circulation, they are released in an immature form, and then they will be circulating in the circulation. Then it will be getting into the tissues after 2 days. Once it remains inside the tissue, it can remain there as phagocytes for years or months. Lymphocytes. They are closely associated with lymphoid tissues. They are important in providing immunity to the body. When you look at the functions, they are classified under different headings. Cell-mediated immunity is provided by T lymphocytes or T cells, which directly acts against the virus-infected cells. The B lymphocytes or B cells, which will give rise to plasma cells, which produce immunoglobulins or antibodies. Leukopoiesis is the production of white blood cells. You can see from this picture that the stem cell is called here as hemocytoblast. Hemocytoblast will be giving rise to two different series of stem cells, a myeloid stem cell series and the lymphoid stem cell series. The myeloid stem cell series will give rise to various cells like red blood cells, platelets, monocytes, myeloblast. It will be giving rise to a series which is the myeloblast, then which will be forming the granulocytes, which are the basophil, eosinophil and neutrophil, which is again I mentioned you before also. You remember it as BEN, B-E-N, basophil, eosinophil and neutrophil, which are the granulocytes of WBCs. The lymphoid series will be giving rise to lymphoblast, and then it will be giving rise to three major type of cells: B cells, lymphocytes and natural killer cells. Now we will see the formation of leukocytes. When it receives specific chemical signals such as inflammatory chemicals, certain bacterial and toxic stimulus, that will stimulate the production of colony stimulating factor or CSF, and also substances like interleukin. So these substances will be stimulating the leukocyte production and its release. The colony stimulating factors and interleukin lead to increase in white blood cell function by directly stimulating the production of leukocytes from the bone marrow. It will also enhance the ability of mature leukocytes to protect the body. Now we will see some of the leukocyte disorders. Leukocytosis, abnormally high count, high cell count, high WBC count is considered to be a leukocytosis. Remember here the morphology of the leukocytes remain normal. Only thing, the count is affected. The count is more than the normal range. Leukopenia, abnormally low WBC count. Here this count is less than the normal range. Leukemia. Leukemia is a cancerous situation. Here there is overproduction of abnormal leukocytes. So please differentiate between leukemia and leukocytosis. Leukocytosis, the cells are normal, but the count is more than the normal. Whereas leukemia, the cells are more than normal, but they are abnormal leukocytes. They are not normal because they are cancerous. Infectious mononucleosis, overproduction of abnormal leukocytes caused by Epstein-Barr virus. It is due to a viral infection. This is another condition which is called as infectious mononucleosis. Leukemia, which means white blood, type of cancer in which leukocytes from a single clone remain immature and proliferate out of control, resulting in the impairment of normal red bone marrow function. There are different types of leukemia. Myelocytic leukemia involves cell descended from the myeloblastic stem cells. Lymphocytic leukemia, which involves the lymphocytes. Increasing infections and hemorrhage are the most common causes of the death in leukemic patients. Platelets are produced from the precursor cells megakaryocytes. Megakaryocytes are the precursor cells from which the platelets are formed. And here is the normal count of platelets. They have a very short lifespan, approximately 8 to 12 days. They are the cells which are involved in the clotting process. If they are not involved in the clotting process, if there was no injury or anything like that, within 10 days usually these cells die off. They approximately measure to about 2 to 4 micrometer in diameter, and the cytoplasmic granule contains several substances like serotonin, calcium, different enzymes, ADP, and platelet-derived factor. Now we will see some of the important events in the hemostasis. Now tell me, what is hemostasis? Hemo refers to blood. Stasis refers to stoppage. So it is the process or the mechanism by which the clotting process will be happening, and thereby it prevents the loss of blood. The first and foremost event that occurs is a vascular spasm. The smooth muscle of the blood vessels contract, which is a vasoconstriction. Why there should be vasoconstriction? Vasoconstriction decreases the diameter of the blood vessels, thereby it can prevent the blood loss. This has partly a neural involvement. Platelet plug formation is the second step. Whenever the blood vessels are cut, the collagen in the blood vessels are exposed, and into this collagen the platelets can go and adhere easily. It will go and attach to these collagens, and some of these platelets which has already gone and attached to the collagen, they will start secreting chemicals, and these chemicals will attract other neighboring platelets to come to that location. Finally, all those platelets will come together and it form a sticky mass, or a platelet plug is formed, and this will be preventing the bleeding to occur. The third and last step involved here is the coagulation, where the actual fibrin, one of the clotting factor, which will be forming the fibrin threads, and these fibrin threads will be acting like a mesh into which the RBCs are trapped in, and platelets will be trapped in. It will be forming a clot, where it will be actually stopping the complete prevention of the blood loss. This picture shows the platelet plug formation. Here you can clearly appreciate the exposed collagen. After the injury, the collagen in this area is exposed, and into that the platelets will get adhered and it will form a platelet plug formation. And you can see that there are various chemicals like thromboxane, ADP, etc. are released, and usually the platelets will get attached to this collagen through a factor which is called as a von Willebrand factor. Von Willebrand factor will be allowing the platelet to get attached to the collagen, and also each of these platelets will be clumped together to form a mass, which are called as a platelet plug formation. This is one of the example for a positive feedback, because initially you are seeing very less amount of platelets, and which will be at the end more and more platelets are coming into that particular location, because these chemicals which are released from the platelets will attract or draw attention of other neighboring platelets to the location. We will look at the functions of platelets. It is one of the most important cell which is involved in the hemostasis to stop the bleeding. Vasoconstriction, which will be released, vasoconstriction, that mechanism where the blood vessels are constricted. One of the substance released is serotonin from the platelets, which cause this vasoconstrictor effect. I also said that it is also partly neural involvement is there in that particular. Though there is serotonin, which is a chemical substance, there is also neural factor involved in the vasoconstrictor. Platelet plug formation, adhesion and aggregation of platelets at the site of injury. Blood coagulation. Clotting factors are activated by platelet-derived factors. So this will be released from the platelets, and that will be triggering the clotting factors. All those clotting factors in the plasma, they are in inactive form. They will get activated when this platelet factor is released as a result of injury. The last step is called as a clot retraction. The platelets also has certain proteins within inside the platelets. Same like the actin and myosin, what you learned in muscles, the platelets also has certain contractile proteins inside that which are capable of contracting. So you can see that once the clot occurs, after some time the clot becomes more firm. The platelets will be contracting, and contraction of platelets shrink the fibrin mesh, and it will be making that particular structure very, very firm. And that fluid which will be oozing out of that particular clot is the serum. Serum also, in the yesterday's lecture we have seen how a serum is formed. So in the serum, that's a clear fluid without the clotting factors, because the clotting factors will be used up in the clot formation. Then there will be tissue healing and repair, which is mediated again by the platelet derived growth factor. That will be there, and that will be also stimulating the smooth muscles and fibroblasts to divide and rebuild the blood vessel wall. Now let us learn about blood groups. Based on the specific antigen on the surface of the red blood cell membrane, two major systems of blood grouping is seen. ABO system, which is based on antigen A and antigen B. And there is an RH system which is based on antigen. Now let us look at a Landsteiner's law. In this particular picture, you can see the scientist who is the Carl Landsteiner, who was a Nobel laureate for his discovery on the blood groups. He stated two laws, the first law and the second law. Let us see what is the first law saying. If an agglutinogen is present in the RBC of an individual, the corresponding agglutinin must be absent from the plasma. Carefully observe this statement. If an agglutinogen means it is an antigen. Both are ending with the term gen. Agglutinogen, antigen. So please remember, agglutinogen is nothing but they are antigens. So antigens or agglutinogens, they are always present on the surface of the red blood cell. So this law states that if an antigen, that means an agglutinogen, if it is present in the RBC of an individual, the corresponding agglutinin is antibody. The corresponding antibody must be absent from the plasma. If you take an example, an individual with A group of blood group, A group will be having antigen A on the surface of the RBC. Antigen A, if he is A group, he is having antigen A. What will be the antibody present in his plasma? Will he have anti-A in his plasma? Absolutely no. Why it is no? Because if he is having antibody A, this antigen will react with antibody, right? So the first law states that if an agglutinogen is present in the RBC of an individual, the corresponding agglutinin must be absent from the plasma. That means if an individual is with A group, his blood group or his RBC will have antigen A, but it cannot have antibody A in his plasma. But he can have antibody B in his plasma. Because why? Because antibody B cannot react with antigen A. Now the second law states that if the agglutinogen is absent in the individual's RBC, the corresponding agglutinin must be present in the plasma. If the agglutinogen is absent, that means if one antigen is absent in the individual's RBC, the corresponding agglutinin, that means it is the antibody, the corresponding agglutinin, that means it's an antibody, should be present in the plasma. We will see this when we look at the next table. You can look at this table. From this table, you can appreciate that A group individual has only one type of antigen on the red blood cell surface, that is A antigen. And what type of antibody they have it in plasma? They have in the plasma, the antibody is B. B antibodies in the plasma. What about the antigen? Antigen on the cell surface, it is A. That is the fulfilling the first law of Landsteiner, which says that if an antigen is present on the surface, the corresponding antibody should be absent from the plasma. So this fulfills that criteria, because here the antigen is A on the red blood cell, but the antibody is B in the plasma. Similarly, if you look at the individual with B group, here you can see that B group individual is having antigen B on the cell surface, but his antibodies in the plasma, it is anti-A. So anti-A cannot react with antigen B, right? Anti-A has to react with antigen A, right? So that is how this is. What about an individual with AB group? AB group individual will be having both antigen A and antigen B on the RBC surface. What about his antibodies in his plasma? It is none or nil, doesn't have any antibodies. Why it is so? What will happen if there is an antibody which is there, either A or B? Then there will be a cross reaction which can happen. Antigen A will react with antibody A. So that will be happening. So instead of that, it is prevented. What about if the RBC surface doesn't have any of the antigen? Of course, they will be falling under the category of O group, because they don't have any antigen on their cell surface. So their plasma will be having both anti-A and anti-B antibodies. O group individual is called as a universal donor, since O group individual doesn't have A or B antigens on its RBC surface. They will not be attacked by the antibodies A or antibodies B of the recipients of the plasma. So these blood group, they can donate blood to other group. The second consideration is AB group is called as a universal recipient, because their plasma lacks A and B antibodies. They can receive blood from any blood groups of the ABO system. Now this is just in case if we don't get any compatible blood. It is ideally the compatibility of the blood, the cross matching has to be done before the donation of the blood, because this one is applicable only in situations where we don't get the correct compatible group. In those cases, we might consider O group as a universal donor and AB group as a universal recipient. The reason being, there are also some minor blood group other than the ABO system which might be existing in those individuals. So unless we do a minor cross matching and a major cross matching, we will not be able to donate the blood. That is why whenever you want to donate the blood, usually before the donation of the blood, the lab people will be usually doing a cross matching of your blood with the recipient's blood, and they will be seeing whether it is compatible or not. And if the agglutination happens on the slide outside, then he will not be allowed to give the blood. So it should be always make sure that a cross matching of the blood should be done before the donation of the blood, because there might be some minor groups other than the ABO system. Now we will learn about the Rh system. Individuals who have Rh factor, which is an erythrocyte antigen, are called Rh positive individual. Rh factors was first observed in the erythrocyte of a species of monkeys called rhesus monkey. Hence the name Rh or rhesus factor. So rhesus factor came from the term rhesus monkeys. This is the rhesus monkey, and here you can see that the individual which doesn't have any Rh antigen on the surface of the red blood cell, they are termed as Rh negative individual. Whereas here you can see there is an Rh antigen on his cell membrane, on his RBCs, and they are called as Rh positive individual. So this Rh positive individual can be from any group. A group individual who is having an Rh antigen on his surface, he will be called as A positive, and A group individual without Rh antigen on his surface will be called as A negative individual. So that negative and positive, this is based on the presence of Rh antigen on the red blood cell surface. This picture shows a compatibility chart based on the anti-A and anti-B serum when it is mixed with different blood groups. You can see from the above picture that there is a compatibility here because no agglutination is occurring when O group is mixed with A group. But in the second picture, you can see that A group, when it is mixed with O group, you are seeing that there is agglutination which is occurring. When there is agglutination, it is supposed to be incompatible. So before the blood donation, it is mandatory that everyone should do a cross matching before it is donated into the recipient, right? The donor, before giving the blood to the recipient, always the hospital, they'll be doing the cross matching. The minor cross matching and major cross matching will be done there. Now we will see one of the most important complication of the Rh incompatibility, which is called as erythroblastosis fetalis. In this picture, you can see that a man, when he gets married to a woman and when they have a child, you can see that the father is an Rh positive individual. Let us say his blood group is A positive and the mother is O negative. The mother is negative and the father is positive. You can see that the mother is negative, the father is positive. So that means on the surface of the red blood cells of the father, he is having antigen A is there and also Rh antigen is there. But in the case of mother, she is O group, so she doesn't, O negative, so she doesn't have an Rh antigen. But what happens to the fetus? Fetus is having the similar blood group of that of the father in this case. So the fetus is having Rh antigen on the surface. Now what will happen? When the mother, who is Rh negative, is carrying her first Rh fetus, the Rh antigens from the developing fetus can enter the mother's blood during the delivery. Please remember, the blood from the fetus will never get mixed with the mother's blood under normal circumstances because of the presence of placenta. Only during the time of delivery, you can see that there is a mixing of blood, fetal blood with the maternal blood. Otherwise, there might be some situations where there is a rupture of the placental barrier or placental membrane, which is abnormal situation. Under normal situations, you don't see that the blood from the fetus will never get mixed with the blood from the mother. So during the first delivery, what will happen is the cells from the fetus, the blood from the fetus will get mixed with the fetus, with the maternal blood during the time of delivery. Then by the time the delivery has already occurred, the first fetus is safe. The first baby is safe in this case. Now what will happen? In response to the fetal antigen, you can see that in response to the fetal Rh antigens which entered into the mother's blood, the mother will start producing antibody against this Rh antigens. So now what is the status? Here the first delivery was safe, but at the time of delivery, the blood from the fetus has already mixed with the mother's blood. So in the mother's blood, it has received some amount of positive blood from the baby, from the fetus, right? So in that case, the mother will start developing the antigen. So the first baby is already safe because the delivery has already occurred, right? Now what will happen if the second baby or the woman becomes pregnant again for the second time with the similar status? The baby is positive, mother is already negative, father is again positive. So this situation, the baby is positive and the mother is negative. So this situation, if the woman become pregnant with another Rh positive fetus, her Rh antibodies, which is already developed, which was developed in the beginning during the first pregnancy, that will start crossing the barrier, the placental barrier, right? So they will be crossing, they are capable of crossing the barrier. They are IgG type of antibodies, so they will be able to cross the placental barrier, and then they will start attacking the fetal RBCs. The fetal RBCs will start getting destroyed and the fetus might die inside the uterus, and this condition is called as erythroblastosis fetalis. But this kind of things were happening in the olden days, but now it is prevented by immunization. As soon as the first delivery occurs with this kind of a blood grouping situation where the fetus is positive and mother is negative, mother is Rh negative, fetus is Rh positive, if the father is also Rh positive, in that case usually immunization will be given immediately after the first delivery so that the antibody will not be produced in the mother's circulation. So in case if the mother becomes pregnant again with a similar type of baby with Rh positive fetus, then nothing will happen because of this immunization. That's all about this particular part, which is the erythroblastosis fetalis. These are the references. Thank you so much for listening.